And the first time most patients hear of the concept of you're going to put a needle in my eye, sort of they think, what? You're going to put a what in my where? And they sort of cringe, at least internally, if not externally, and I absolutely get that. The reality is, and what patients and referring doctors really need to realize is that we as a community of retina specialists are exceptionally good at doing this. We've been doing this a lot now for a decade. The vast majority of patients have no pain. The vast majority of my patients, the first time I do it, look at me and literally say, that's it, we're all done. Patients can tolerate it really well in the hands of people that really know what they're doing when they give these injections. It should not be painful. And the other challenge to realize is that the injections really work. Like, these aren't just well, let's try the injections and hope that they work. The data is overwhelmingly positive that it slows progression and improves visual outcomes in these patients. And vision's really important. You know, it's easy for all of us, I think, to take vision for granted. But once you have a visual problem, patients very quickly realize how valuable vision really is to their everyday life. Aflibercept has turned out to be an incredibly powerful and valuable medication in the treatment of many retinal vascular diseases. And fortunately, it's used incredibly frequently across this country and around the world. We are still learning about more indications for aflibercept, and I think that there's a long way to go yet of its use. This is a complex landscape for patients and referring doctors to navigate, and I sort of, most broadly, there's two kinds of eye care professionals. There's optometrists, whose degree is an OD, and then there's ophthalmologists, whose degree is an MD. Very different trainings to become an optometrist and to become an ophthalmologist. They both are incredibly important for primary eye care. So most optometrists and most ophthalmologists can do diabetic screenings. So I don't want patients to be worried about that. Get into any eye care professional. It's better to see one than none, for sure. Once you have diabetic retinopathy, and especially diabetic macular edema or proliferative diabetic retinopathy, the other major flavor of diabetic retinopathy that causes vision loss, it's important to get into a retina specialist. Now, what is that? Well, within the MD category, within the ophthalmology category, there are multiple different fellowship training specialties, right? There's glaucoma, there's neuro-ophthalmology, there's plastics, and there's retina. And retina is usually a 2-year fellowship where you specialize in both the medical and surgical management of complex diseases of the back of the eye. And diabetic retinopathy is one of the most common things that we manage on a daily basis. Fortunately, we have developed a tremendous number of valuable pharmacologic agents over the last decade. We have 4 FDA-approved medications now, all given by direct injection into the back of the eye for diabetic macular edema itself, whereas a decade ago we had none. So that's been a huge revolution for patients and physicians. And I think the number of medications that we'll have access to will just continue to grow. The surgical space also continues to expand. The devices space continues to expand. We have great lasers now that are more effective and safer than they were even just a few years ago. So the field continues to grow, and it's an exciting time to be a physician, and the patients are getting more and more benefit. So it's good.